I just want to say again, welcome. Thank you guys all for coming. I hope you have had a chance, or you do have a chance, to get outside and enjoy this gorgeous weather. We have a few months of this, and then we get the white stuff, so take it while you can. Your lunch will be coming soon, so I'm going to introduce the next speaker. It's going to be, excuse me, I got to use these. Dr. Kathleen Murphy. She's the project director for Center on Knowledge Translation for Employment Research, also called KTER. She's the principal researcher at the Austin, Texas office of American Institutes for Research, and she's going to talk to us about the State of the Science Conference. Welcome, Kathleen.
Well, thanks. So I won't take too much of your time, but I did just want to thank the VR Summit organizers for letting us have our State of the Science as part of an embedded track. It's been a great way to reach a VR audience, and that's really been our primary goal for the last 4 years. The idea of the State of the Science is that not only do we at the KTER Center take the opportunity to let you know what we've been doing for the last 4 years, which involves some of you and or your staff, but also to bring in other NIDLR grantees who are doing work in the disability employment field. So we hope that you'll take the opportunity to look at the track. There's more handouts at the welcome desk if you're curious about, well, you know, which one of those sessions do relate to the KTER State of the Science track, and you'll get, by attending those sessions, you'll get a chance to see what the National Institute on Disability, Independent Living, and Rehabilitation Research has been funding to help you do your job and bring us all to the outcomes that we care about with respect to disability employment. So one thing that KTER has done is do a knowledge brokering study. We presented on that this morning. And some of you may be thinking to yourself, what is knowledge brokering? Where did that idea come from? Why did KTER choose to look at that? And we have the great good opportunity over the next few minutes to hear from our next speaker, Maureen Dobbins, who's an expert on knowledge brokering and joins us from our neighbor to the north, Canada. We also are coming out of, Maureen and I and some of us, from the roundtable. That was the follow-up to the knowledge brokering formal presentation. And we heard a lot about various issues that are facing VR as a whole. There's been a lot of change with the Workforce Innovation and Opportunity Act. There's a lot of things having to do with really agency management. And it illustrated to me the importance of looking outside of disability and rehabilitation research for some of the answers to the questions that we have. It's pretty obvious that if research is going to help this field, it can't be restricted only to disability and rehabilitation research. We need to start looking at industrial and organizational culture, what's going on in knowledge translation more broadly speaking. And so this next few minutes is an illustration of the value of looking outside of VR. Our speaker, Maureen Dobbins, is from a school of nursing at McMaster University. She's been there for 20 years. She is currently a professor, and she holds appointments and brings a background in clinical epidemiology and biostatistics, the School of Rehabilitation Sciences, and the Masters of Science in e-Health program. So similar to the KTER Center, she has sought to understand knowledge translation, and the difference, though, is that she looks specifically at audiences in public health and public health decision makers. So that's an analogous audience to you state directors of VR who are making decisions, and some of the agency staff we have with us. Her program of research, again, similar to the work that NIDLR funds in knowledge translation, has looked at barriers and facilitators to research use. Why would a VR counselor ever use research or not? What are the information needs of the audiences that are out there? What should we be, trying to promote the uptake of? She's developed, she's implemented, she's evaluated a variety of knowledge translation strategies, not only knowledge brokering. And for the past 18 years, she's been the director of health evidence. It is a source of high-quality effectiveness evidence, and just one component of looking at how do you think about knowledge translation comprehensively. You know, it's obviously, knowledge translation is not just doing a webcast, putting out a newsletter, doing, you know, one-shot trainings. It's really thinking through what would motivate someone to use research, what research do they need, what strategies are out there, how do we implement effectiveness and look at sustainability. And one resource that Maureen brings to us is that she is the scientific director of the National Collaborating Center for Methods and Tools. So it's NCCMT, you can Google it, and they have a really comprehensive website that offers a lot of toolkits and measures and tools, right, to help us think through some of the challenges we're facing. It's one of 6 national collaboration centers for public health in Canada. It shares the mission of the KTER Center of putting research evidence into policy and practice. So I think, Maureen, are you ready to join us? So please give her a hand before and after. We love our friends from Canada.
Thank you so much, and thank you to the organizers for the invitation to be here today. I'm just going to have my phone up here and just to keep myself on track with time, and glasses to be able to see some notes that I made for myself. You know, interestingly, when I was younger, I used to love being able to say, I've been doing this for 10 years or 15 years, and now when I hear things like 20 years or longer now, that just makes me feel old. So I need to take all those times out of any of my resume stuff. But it's my pleasure to be here today to talk to you about, I guess, the journey that I've been on and impart what I've learned about knowledge translation and about knowledge brokering over the past number of years. I guess one of the titles I could have given for myself is knowledge broker, and that's actually really I think how I've ended up being here today is that I think for most of my career I've been really interested in helping who I was as a public health nurse. So when I started public health nursing 30 years ago, right about now, you know, I went into public health nursing with a nursing degree, and I had the good fortune to go to McMaster University, and one of the things I learned about in my program at McMaster was how to critically appraise research evidence and how to think about using that in my practice. That was very much a part of my program. And in fact, one of my lifelong mentors who continues to work with me and mentor me today, Dr. Donna Saliska, actually taught me that course in third-year university, and we've continued to work together in this work in knowledge brokering and evidence-informed decision-making in public health. But I went into practice as a public health nurse understanding the importance of using lots of different kinds of evidence, one component of which is research evidence, having some skill in terms of being able to tell the difference between research that's good enough to inform our practice. But I struggled as a public health nurse in how to make time out of my really busy day-to-day work to incorporate taking the time to look at the evidence. I also had the good fortune of starting working at a public health unit in Hamilton, just down the road from McMaster University, that was had a culture of wanting us, the staff, to use evidence in our practice. And even within that, it was still really challenging to find the time to say, well, should I spend some time reading these articles, or would I be out there working with my clients? Because that's really what seemed to be the most important thing for me to be doing. And sometimes what I would end up doing is taking that research home and trying to make time to do that reading at home and think about how to apply it. But found that I wasn't very effective at being able to do that either, carving out that time regularly at home. And I think that's where a lot of my ideas started to come from. As I moved into graduate school and started exploring what was involved in evidence-informed decision-making, which is a term that we use in Canada. What has driven me for the last many years is how can I make life better for that person I was as a public health nurse, who was really keen to use the research evidence, who wanted to not just do practice because that was the way we've always done it. So to want to know that what we were offering was the most effective practice, but struggling to find the time to do it. My work as a researcher has been, how do we figure out what I would have needed back then? How do we work collaboratively with public health to develop resources and tools that will be useful, so that that would have been easier for me to do. And while I was really lucky, I seemed to finish my PhD just as we created an organization in Canada called the Canadian Institutes for Health Research, which was created with a mandate from the federal government to demonstrate how the money being invested in health research in Canada was actually changing healthcare and patient and population outcomes. So this organization was just being created at the time that I finished my PhD, and there was a whole new set of money set aside for research in what we call in Canada knowledge translation. Similar terms in the US are dissemination and implementation. And then a few years into that, there was also the term knowledge brokering that evolved. So I'm going to talk a little bit about that research, and also a little bit about the center I've had the pleasure of running for the last several years, which is less about doing research and more about supporting public health to use research. So really we're acting as knowledge translators and knowledge brokers to help a sector, public health in Canada, use the best available evidence. So I'm going to talk for about 45 minutes and definitely want to leave some time for questions at the end. So we're going to start with talking a little bit about a question Kathleen just asked, like really what is knowledge brokering? And actually there's many different things that it can be. What does the science currently say about knowledge brokering? I'm going to talk a little bit about the term we use in Canada that is called evidence-informed decision-making and the model that guides the work that we do. We've also been looking to theories around the stages of change to help us as an organization identify what we're doing and better capture for our funder, the Public Health Agency of Canada, what their return on investment is in funding us right now for 12 years and 8 more to come starting next April. So we constantly are being asked to justify what are you doing with the money we give you, and how do we know that it's actually making a difference in public health. And at the same time, I'm trying to think about how this is relevant to the area that you work in. And I think there's a lot of similarities in terms of, while I focus on trying to change practitioner behaviors among the public health workforce that I work with are trying to change health behaviors of their clients, primarily marginalized populations in Canada. And one of the things that I learned along the way, my training as a public health nurse, actually, I didn't know it at the time, but set me up perfectly to be a knowledge broker, because working with high-risk families, new mothers and fathers was what I focused on when I first started nursing. And what we learned when you went into people's homes is that you didn't tell anybody what they had to be doing, what they should be doing. You always worked very collaboratively with them to develop a relationship, a partnership, to set mutual goals that you would work on. And you were imparting information and supporting and guiding and learning from them about what their needs are, so lots of assessment. And I didn't realize at the time that those were the skills that I would need as a knowledge broker, and definitely as a researcher who does work in knowledge translation. Those are the kinds of skills that actually have really supported the type of work that I've done collaboratively with public health and all of the research that I've done has been done collaboratively with public health, telling me what they need and helping me develop the tools and resources. So we'll talk a little bit about that and then finish with some questions. Just a little bit about who we are. So as Kathleen said, I'm one of 6 centers that are funded by what is called the Public Health Agency of Canada. And the 6 NCCs, our name was given to us. It probably wouldn't have been what I chose, but what the name implies is that the 6 centers that are located from coast to coast and cover quite a variety of topics, we work together to help build knowledge, skill, and capacity amongst the public health workforce in Canada to use the best available evidence, and that's not just research evidence, that's the whole gamut of the different kinds of evidence that inform public health and population health practices, policies, and programs. We really came out of the SARS epidemic that, if you're not aware, Toronto was really an epicenter for a relatively large number of deaths. And of the many inquiries that came out of SARS, it was identified that the public health community really lacked skill and capacity to be able to utilize best available evidence during that crisis. And from that, the Public Health Agency was created, as well as then work was put in place to put these centers in place. You can see here that we are coast to coast, not as we would now say coast to coast to coast up in the north, but we cover the determinants of health, healthy public policy. We're a bit fuzzy like methods and tools, but that's methods and tools related to knowledge translation. We have one on infectious diseases, and then on our west coast, 2 that are related to environmental health and Aboriginal health. Actually, my mistake in not changing this, they have recently changed their name to Indigenous health. So our specific mandate is to enhance evidence-informed public health, both at the practice level, programs and policies, as well as to provide leadership and expertise to support the uptake of what works in public health. And so that's not only what interventions, policies, or programs work, are effective in improving public health and population health outcomes, but also what works in knowledge translation. So we can be both a support to the public health workforce as well as the other NCCs. And I will talk in a few moments about what I mean when I talk about evidence-informed public health or evidence-informed decision-making. We do this in a variety of ways. So we're actually a pretty small center. We might have at any given time 8 to 10 to 12 full-time staff working with us. So we're not that big, but we have a very large geographic area that we need to cover. And certainly when we're federally funded, you need to make sure that you are helping everyone in the entire country, which basically means that we can't physically visit everybody and see everyone. We can't have that one-to-one type of relationship in a face-to-face way as perhaps we would like. So it's really forced us to think about how do we create resources and tools that everyone in the country can access at any time. So much of what we've created, whether it's around capacity development or networking and outreach, is available online. And Kathleen talked about that. If you visit us at nccmt.ca, everything my center has created is available online in both English and French and is freely available to anyone to access around the world. When we first started thinking about how do we go about delivering this, what we think is a fairly huge mandate, we really created some specific areas that we wanted to focus on. So we have some repositories, knowledge repositories that house different kinds of evidence, whether it's on the effectiveness of public health interventions or the effectiveness of different types of knowledge translation interventions. We are engaged in different types of capacity development, whether that's in face-to-face workshops or in online learning modules or in our knowledge broker mentoring program, which I'll tell you a bit more about later. We've also created a variety of videos to help break down some complex statistical concepts, made those available. And then also really, really importantly is to connect public health folks from across the country. In our ability to talk to public health professionals who work in Newfoundland almost at the same time that we're talking to those that work in British Columbia, so across 5 time zones, I think it is about 7 hours from coast to coast, we learned that public health professionals are grappling with the same issues all over the country and looking to the evidence to help support what they should be doing. And many times they have the same types of questions. And our brokering role, when we interact with someone in Newfoundland and find out that someone in British Columbia at the same time is having the same type of question, we're able to connect them to say, hey, did you know they have the same question? They're looking at some of this. Maybe you guys should speak together and maybe work on this together. So that's also a really important part of what we do, is helping the sector share their knowledge with each other and developing mechanisms that would allow them to know what others are dealing with and how they might be able to help each other. So that gets a little bit about what our role as knowledge brokers are, and this really is just a definition that I took from Wikipedia, but very interestingly is mimicked in much of the literature that we see. A knowledge broker we think about it as an intermediary person. It can be a person or an organization, and they aim to develop relationships and networks with, among, and between producers and users of knowledge by providing either linkages, knowledge sources, and in some cases the knowledge itself, such as how to do certain things or tools, to various organizations in its network. I would say that there are multiple definitions of knowledge brokering. This one is a catch-all that really brings all of it into place. In 2005, we had an organization in Canada called the Canadian Health Services Research Institute, and they started writing about knowledge brokering, and they really envisioned knowledge brokering as an intermediary person that brought together the knowledge producers and the knowledge users, brought them together to be able to have conversations with each other so that you could each talk about what their needs were and then work together in co-developing, let's say, research projects that could answer questions. And it's an interesting definition of the word broker, because it really had this person that was bringing 2 different groups together and almost in essence helping them have conversations with each other, because at that time we believed that the researchers really struggled to understand what decision makers and policymakers needed and wanted, and the policymakers would say, I don't really understand when those researchers start talking, I don't know what they're saying. So it was really helping to bring them together and have meaningful dialogue. At the same time, I had already been doing some research, trying to support the use of evidence amongst public health professionals. And I thought of knowledge brokering a little bit differently. I thought about it as not bringing the researchers and decision makers together, but actually a person that could say, amongst this workforce of public health professionals, where there's already an existing body of research that can be used to inform some decision-making around programming, how do we, is there an opportunity for a broker to help the public health professionals become more aware of that evidence? And as we got into some of that work, then we also started to realize that there were some limitations in their knowledge and skill and capacity to be able to use that evidence in practice and to apply it to their local jurisdictions. So even way back in 2005, we had some fairly different definitions about what knowledge brokering could be, and I don't think there's any one right way to do knowledge brokering. I think it depends on what context you're in. So my work always developed around working collaboratively as this broker to work within public health, and then we've done some expansion from there. So in the field of public health, knowledge brokers, what we've been working on, facilitate the appropriate use of the best available research evidence in decision-making processes, enhancing both individual and organizational capacity to participate effectively in the decision-making process. So that's one way to think about that. And in the session that I was in with Kathleen, sorry, I just need some notes here. This morning, I was thinking about a few of the comments that were made in that session, and I think something that's really, really important that I say all the time to public health professionals when we talk about evidence-informed decision-making, EIDM, is that it's using the best available evidence at the time, knowing that the evidence base is always changing. And we can say the same thing for the knowledge brokering field or the knowledge translationing field. My center, Kathleen's center, I mean, it's a work in progress right now. There's still so much to learn as we develop our ideas and implement ideas around knowledge brokering and evaluate them and then take that evaluation into consideration. So thinking about that the knowledge base is constantly changing and being really reflective about what worked, what didn't work, to help inform those next steps, both in knowledge brokering and in knowledge translation, is really important. So to setting that stage a bit about how we've envisioned knowledge brokering, then we start to think about, so what are the activities that one would do as a knowledge broker? I'll suggest just some of them here. We could divide them into three. I'm only going to talk about three today. Knowledge management, linkage and exchange, and capacity development are the ones I'm going to focus on. When we think about knowledge management, what the literature would tell us is that as knowledge brokers, we identify and obtain relevant information. That also means that we need to understand what the needs of the knowledge users are, so assessment of what would be relevant to them is really important. Facilitating development of analytic and interpretive skills, creating tailored knowledge products for different types of decision makers, and this would be even within the same organization. That could be by different disciplines or different levels of decision making. They're project coordinators. They need to support communication and knowledge sharing, and monitor the process of implementation. One thing that I talk a little bit about from the public health perspective, and this may be similar in your field as well, is that in public health, people arrive in public health from many different backgrounds. So while we have a few undergraduate programs in Canada that are public health programs, mostly public health professionals are nurses, dietitians, health promoters, some epidemiologists, some public health inspectors. So people come to public health with many different undergraduate and graduate degrees, and most of the degrees that they come from, very few of them would ever find themselves working in public health. So when we think about trying to train the next generation of public health professionals, we can't just, as a center, can't just go and try to impact those educational programs because it's very, very vast. So we usually end up needing to do a lot of this work to facilitate evidence-informed decision-making once they're in public health to gain those skills. So those are some of the knowledge management activities that brokers would do. They're also very heavily involved in linkage and exchange. So they identify, engage, and connect with stakeholders, facilitate collaboration. They connect stakeholders to the relevant information sources. When I first, I would say, fell into this field a long time ago, it seemed like what was a fair comment to say was that there wasn't evidence that answered my question about what was effective in public health. There was a real lack of rigorous studies that really informed what we would do in public health. That's no longer the case for the great majority of issues that we face in public health. There's now, at the other end extreme, we have too much evidence and we can't keep up with it. As an example, just when we think about chronic disease prevention, and if we take one topic, promoting physical activity across the lifespan, we now have well over 1,000 reviews of the literature. Not all of them would be systematic reviews, but reviews that evaluate multiple studies, those 1,000 reviews representing 10 to 15,000 primary studies. So just keeping up in the field of physical activity, even if you focus that on children, as I've done in certain areas, now we have hundreds of reviews that have compiled evidence on that. So it's ensuring that stakeholders know that that relevant information is there, and then as it becomes too much, where can they go where some of that might be synthesized? Supporting peer-to-peer learning, and again, this is where I think knowledge brokering can come in, communication and information sharing, and then of course that network development, maintenance, and facilitation. And then if we think about capacity development, this is where my center spends a fair amount of its time focused. We can think about how do we develop knowledge and skill in defining problems, taking local data, figuring out what those issues are, and then turning that into a focused, answerable question. And that actually intuitively seems like it really shouldn't be all that hard to do that. But I work really closely with public health professionals, and this is actually a really, really important thing to do and a harder thing to do, and really a good thing to do at a team level, because really defining what that problem is and thinking about who is the population that we're interested in, what are the interventions we want to know about, or programs, what are we comparing that to, and what are the outcomes that we're really interested in knowing something about, and having a team figure that out. You can really see the differences that people have in their minds about these types of questions, and really focusing on coming to consensus on what that is, so that whatever work that is done to compile the evidence does actually in the end answer that question. Developing capacity about appraising the quality of evidence. We certainly spend a lot of time on that, knowing that many don't enter the field really confident in knowing how to do that. And certainly, while it's still apparent today, there's a wide variety in the quality of evidence that is available. And that's not to say that in appraising it, it's to disregard lower quality evidence, but actually to have a better appreciation of the limitations of research, what impact does that have on how we interpret those results, and if we should have any caution in implementing them. We design and deliver tailored training sessions, facilitate knowledge dissemination. It's really important to assess readiness and capacity for change, and that's at the individual level and also at the organizational level. So we do a lot of thinking about who's ready for this, who's showing those signs that they want to move forward, understanding that, and then working, developing programs and strategies, interventions where people are at, starting where people are at and building on their strengths is really, really important. I wrote in here, generate buy-in among stakeholders, and I really don't like the word buy-in. I've never really thought that buy-in has a place in terms of evidence-informed decision-making, knowledge translation, and with knowledge brokers. If we really are engaging our stakeholders very early on in the process, we don't get their buy-in. They're a part of it. They're wanting to be there because there's an issue they are passionate about that needs to be solved. And that is, to me, a much better place to do this work from than actually figuring something out and then trying to get someone to take it up later. So much to the chagrin of many of my colleagues at McMaster, when I finished my PhD and was when this new research institute was started, one of the first things that they changed in research funding in Canada was that you had to write a little paragraph about how you were going to disseminate and promote the uptake of your research when it was done. And so I quickly became the go-to person at McMaster that was to help everybody write that paragraph. And yet I came from the camp that said, well, actually, if you've done your research really well, you would already have those stakeholders involved in the research, so you wouldn't be getting their buy-in after the fact. So many of them had to go back and think, okay, we didn't have any of our stakeholders involved at the beginning. What are we going to do now? We've learned along the way that we can do all the training we want with individuals in organizations in public health, but if they don't work in an organization that values the use of evidence in practice and actually function in a way that supports the use of evidence, then I started to feel like we might actually be harming people because we were showing them a different way to practice, but they didn't work somewhere that actually really encouraged that or facilitated that to happen. So now we really do both together. We work with organizations that really are committed and see the importance of using evidence at the same time that we then start developing the capacity in the staff. And that we think will help with sustaining that organizational engagement. My first study in knowledge brokering actually was in the mid-2000s. And one of the things that was interesting at the time when I was recruiting the knowledge broker for my randomized control trial was thinking about, well, what would be the characteristics of an effective knowledge broker? And interestingly enough, while we do have a list here of the types of characteristics, we still have a lot to learn about what are those characteristics. Are you born with them, or can you be trained with them? And so some of the ones that we see here, someone that has the ability to be a networker, to facilitate networks, who's really good at problem solving, innovating. They need to be trusted and credible. Many of you will know this. They need to be clear communicators. They need to understand, in the way that we've envisioned knowledge brokering, they need to understand the culture of both the decision maker and the research world. And even better if they can really feel comfortable going back and forth between the two. They need skills in being able to find and assess and interpret different kinds of research evidence in different formats. They need to be able to really talk about the findings of research in really accessible ways to many different kinds of audiences. So the way that I would talk about research to a medical officer of health is not the way I would speak to a director in that same organization, not the same way I would message it to managers, and not the same way I would message it to frontline staff. So a really efficient knowledge broker will develop ease in their ability to translate evidence in different ways. They need to facilitate, mediate, negotiate, and really think about adult learning principles as well. In terms of, you need a very special approach to being able to bring people together who have very different ideas potentially about research, about maybe a hierarchy of research. We might bring people together in a room where some think randomized control trials are it. That's the only thing they want to consider, wouldn't consider any type of qualitative research, and we need to be able to help them understand we need all the evidence we can get our hands on, and it all is important at different times in the decision-making process. So we need to think carefully about how we interact and develop collaborative partnerships as people are learning. So I've often thought about a term which is symbiosis. Some of these to me are very relevant to the term knowledge brokering, and really for us in the work we've done for years, it's the mutualism, where both organisms benefit. So when we think about some forms of knowledge brokering, and certainly in the way that we've been doing brokering for the last several years, we are working very closely with public health to help them develop some knowledge and skill and think about how do we do work in a different way. But at the same time, we've learned from the decision makers we've worked with just how the work happens and how the organization functions. And they've been actually extremely generous in sharing that knowledge with us so that we can develop resources that actually are relevant, feasible, applicable to the different types of settings that folks work in public health. So I very much think of knowledge brokering as a two-way street. For as much as we've worked with public health to help them with various decisions and capacity development, they've really helped us along the way in terms of understanding what the practice realities are so that the resources we put in place will be useful to them. In the original knowledge brokering definition that I gave you, where it was that intermediary person bringing two people together, that might be more like the second one here, which is where one benefits and maybe the other is unaffected. So that could possibly be another way to think about knowledge brokering. And we'd really hope that the latter ones here are not necessarily what we're achieving, but to me it was always felt like this idea of symbiosis, some parts of it were really key to knowledge brokering. So I just want to talk a little bit about knowledge brokering impact. So it's not great news when we look at the literature right now. I guess there's two key things that jump out of the few reviews that have been published over the last few years, is that there isn't a lot of research yet on knowledge brokering, and that we need knowledge brokering studies to be happening in many diverse settings, fields, and using different types of methodologies to then synthesize that. So that there is a way to bring together the knowledge brokering work and studies that I do in public health with the work that Kathleen's group is doing. We need more studies to help us build our understanding of what is happening in knowledge brokering. And the reviews that are out there currently tell us more rigor is needed in those, in the primary studies that are being done. So some of them, not to say that I'm talking about randomized controlled trials, but just in whatever the research design is that's being used, it is the most rigorous that is appropriate. And certainly any of you that may have read the result of my the first knowledge brokering trial I did in the early 2000s, one of the final recommendations I gave in that paper was that we not use a randomized control design to evaluate knowledge brokering, because it really doesn't fit that type of approach in that I don't believe there's any way to really randomly allocate organizations that will then have two equal groups. And in the way we did knowledge brokering, there was no one single intervention that anyone received in that. What we do know a bit about in terms of the impact is that there does appear to be a link, and I use the word may, because of the limitations of the existing literature. But there does appear to be a link between what knowledge brokers are doing and an increase in knowledge skills and changes in practice behaviors that align with what the best available evidence says. So there's great promise in knowledge brokering, but we have a lot more work to do to really understand it. So I just want to tell you a little bit more about evidence-informed decision-making, and this is the model that we use. And this was a really helpful model that's been around in Canada for a number of years now. This really gets at the complexity of decision-making. In the early days of research dissemination or knowledge transfer and exchange, so early 2000s, many talked about that we were talking about just using research evidence and not thinking about all of the other things that go into decision making. And that really isn't what we're talking about with evidence-informed decision making. This model helps depict that we know in public health, and I would think in your field as well, that decision-making is really complex, and it's made up of lots of different inputs, one of which is research evidence, others is community health issues, local context, community and societal political preferences, and the kinds of resources that we have, both financial and at the individual level. And that then it's our public health expertise that helps us gather data in all of these spheres and then think about the local implications and then use that to apply it in what makes sense jurisdictionally. And what this allows us to think about, even just in my own province in Ontario, is that what we might do in Hamilton, which is in southern Ontario, using the same information in that purple bubble, using the same research information, but when we look at all of the other data collected in the other bubbles, if I'm in northern Ontario, we might actually make a different decision based on what our local needs are. And all of that would still constitute evidence-informed decision-making. It's an incorporation of the research evidence and all of this other evidence to think carefully about what makes sense for our local area and then to implement that. And I just have a few pictures here because sometimes it's really hard to think about, well, what does that really mean? And I have a few examples that really help talk about what is this thing we call evidence-informed decision-making. These are our mountains in Ontario. They're not really mountains, but they used to be mountains. And this actually is Killarney Provincial Park. And the reason why I put this up here is when I think about the process of evidence-informed decision-making, many of our models that have been developed, particularly in the early years, were depicted very linear decision-making processes that had a defined start and stop point. And really, those of you that have been involved in decision-making know that decision-making isn't linear. It isn't always rational. It doesn't only go in one direction. And so when we think about decision-making, we need to think of something that's probably a bit more like a circular process, which brought me to a backpacking trail that is in Killarney that is a loop. And you can start it in any direction. And it also depicts, to get to this vantage point here, is a huge amount of work that, in getting there, you're usually asking yourself, why did I think this was a good idea? Why did I want to do this? But then you come and you have a great view and then you think this was totally worth it. And that's a little bit about what EIDM is all about, is that it is really, really hard work. There's no one right way to do it. But there can be some great gains to be had in putting in that work to achieve it. It's not the only picture I'm going to show you about EIDM because in this particular instance, you can do this by yourself or you could do it as a group. And you're basically told, as you would in similar trails here, make sure you can do it by yourself because you need to be self-sufficient. We're not just going to come in and help you. And that's really not what EIDM is about. And so I have this one here as well, which is about a summit. This one happens to be of Kilimanjaro. But the reason why I show you this is about a team effort. So to summit Kilimanjaro requires many different people to work together in order to be able to achieve that goal. And that's what we need to achieve evidence-informed decision-making. And then this last one here is about, well, it might not seem like it. It might seem like trust. And this is all about trust in that you're out for a nice little walk on a glacier and quickly told that you need to just cross this ladder over a big drop in order to continue on with the rest of your day. And you need to trust that the people that are setting that up have really done that properly. And trust is really important in evidence-informed decision-making and in our work. We need to develop trusting relationships with those we want to work with. And sometimes it can be really difficult to reflect and identify, particularly if you were a manager or a director, what you don't know in order to be able to use evidence in practice. And you need to be able to trust who you're working with to use that information carefully. Something else that guides our work and is now very much in transition. So when we first started with this very big open field, what were we going to focus working on when we first started doing our capacity development with the National Collaborating Center? So we decided there was this model here that is a 7-step process that we could start with, and we've developed all of our resources actually really aligned to these 7 steps. Defining a problem, finding the relevant evidence efficiently and effectively, being able to sift through that evidence to understand its quality, knowing how to synthesize it, figuring out how to adapt it to be relevant and applicable to the local setting. Now, if I want to change practice, how do I go about doing that? Whether I have 3 staff or 500 staff or 1,000 staff, how do we go about implementing an organizational change to change practice? And then how do we evaluate? How do we know that we've changed practice and that everybody is doing the new behavior that we're hoping they're doing? And if we have changed practice, how do we know we're actually having that change impact on the health outcome that we were interested in? So we started with that. Sorry, just go back there for a moment. We started with this model, and we've been focused on this for quite a bit of time. And now we've realized it's time to evolve, in that this is only one very small part of the capacity that folks need to have, and it's only one small part of decision making. We really need to think about now how this really focuses a lot more on some of the research evidence, but how do we incorporate the evidence from the other bubbles that I was just showing you, the local context and the societal preferences and the resources? How do we fit all of that together within a decision-making process that an organization may have? So we're embarking on a multi-year program, again, working really collaboratively with public health to figure out what changes need to be made to our models that adequately reflect the realities of the practice setting. So in terms of some of the similarities between public health and the VR setting and knowledge brokering, you know, that idea of changing health professional behavior, that's what we're doing. You have the various professionals that you're working with. How do we go about changing behavior, particularly when everybody is really, really busy? How do we promote that? Changing our clients' behavior with the idea that that's what's driving us for the different kinds of outcomes that we're looking for. And then the context and the culture. We've had a few things that have helped us out in Canada in terms of both at the national level and in some of the provinces, where the expectation to demonstrate the use of evidence in practice is very up front and center. It's actually been written into a number of standards for public health practice that the onus is on public health professionals to demonstrate that they are in fact practicing in an evidence-informed way. And so that's really driving the culture and the context of the public health setting to be changing, to then be really ready for moving in this direction. So looking for those kinds of drivers is really important. So I want to talk a little bit more about where do practitioners fit in, and I use that word lightly. So we could put counselors in here. We could say the workforce, but specifically, what's the call to action for the frontline folks in terms of how can I, as one person, have an impact in my organization in evidence-informed decision-making? We can always be questioning practice. If we've been doing the same thing for several years, maybe we should be thinking, is there anything, how do I know this is still the best thing that I should be doing? Because the knowledge is constantly changing. We need to be critical consumers of everything that passes by our devices, our screens, because a fair amount of it perhaps isn't something that should greatly influence our thinking. I need to have new knowledge. I need to be constantly developing new skills. How can I be involved in program decisions? Can I have any impact on organizational structure? And where we've been working a bit more is in influencing and motivating our peers. I'm just going to go through these quickly. I think I'm quickly running out of time. So as knowledge brokers, we usually experience lots of different types of reactions, and some of these I'm sure will resonate with you. This one here is, you know, where everyone just has their head down, hoping that if we just keep quiet long enough, this will all go away and everything will go back to normal. That's really what we have to know, how to deal with that. Or other times people are really quite openly resistant and want to push us back. We need to have strategies for how to deal with that. Or people that are really, really on board and are wanting to get going really, really quickly, and that might even be a little bit uncomfortable for us. One of the things we've done in terms of thinking about how do we break down what we're doing using a theory of change, we have really thought about our work in 4 ways, where we are developing products that may help, that we think will help the workforce develop new skills. That moves towards public health professionals then seeing us as the go-to place to access that information, and we start to see use of those. So the actual accessing of the resources that will help build capacity. We then start to see a need to actively measure whether or not health professionals are engaging in the what we call EIDM behaviors, and then seeing if we see a change in practice. So that's how we've really started to think about, of all the data that we collect, when we try to pull it all together to tell a convincing story to our funder that we're making an impact, this is the type of approach that we've looked at. So I just want to finish with a couple of examples. So we did what was called a Partnership for Health System Improvement study a few years ago. And this is where this funding competition required me to have, as a co-primary investigator with me, decision makers. So as a researcher, I needed to have an equal counterpart who came from the public health community. I actually had 3 medical officers of health who partnered with me as primary investigators. And they also had to provide 30% of the funding to do the research in order for me to be able to apply for the program. And we wanted to know what the impact of a tailored knowledge brokering intervention would have on knowledge, capacity, and behavior for EIDM, and also what factors would facilitate it. We worked really intensively with 3 public health units in Ontario, and we developed 3 different interventions based on the needs of that organization. So we've spent a lot of time really assessing what those organizations needed and wanted. And in fact, with the way funding cycles go, it was over a year from the time we did the initial development of the grant to receiving the money, to being ready to implement. Even by then, the organizations had changed what their needs were, and we needed to respond to that and change what our intervention would be, which we were able to do. Just in terms of, with all of them, we did a lot of capacity development. Many of them were involved in doing their own rapid synthesis of the evidence. We did large-scale training. We did lots of interaction with senior management. So it was a very mixed type of intervention. And just a little bit about what we found was that just attending large group training sessions was not effective in changing behaviors related to EIDM, but those who worked significantly over a prolonged period of time with the knowledge broker definitely showed significant improvements in their evidence-informed decision-making behavior, as well as in their knowledge and skill related to the tasks of evidence-informed behavior. There were lots of things that were important around supporting the contextual factors. So certainly the knowledge broker being embedded within the organization was important, and having knowledge and skill and rapport with the workforce. In all of the organizations, evidence-informed decision-making was a priority, and where there was the most senior leadership support and modeling of the behavior, we tended to see the biggest gains. As always, things that can get in the way: time, competing priorities, lots of anxiety and uncertainty about what was the expectations for staff to engage in this. So whenever we could get senior management to be clarifying clearly what the expectations were, this was definitely helpful. The library services could sometimes work in a way that was opposite to what we were trying to promote, so that was really important to address. And then, of course, everyone has different definitions of what evidence-informed decision-making is, so coming to some consensus on what that was. So this actually helped us think about, we needed to be working with organizations at the same time that we were developing capacity in individuals. That we needed this to be a team effort, that you don't just train one or two people, it needed to be many people, and that you needed to be thinking about where did this fit in the broader mandate of that organization. I'm going to skip over this. This is, again, what we're currently doing is a knowledge broker mentoring program. We've taken the results of that study and really used that to inform a program that we now deliver across the country. If I just go back, so far we've had 10 organizations across 2 cohorts participate in this program, and we work intensively with organizations over about 2 years of time to develop, again, individual capacity as well as organizational mechanisms and processes. And I'll just talk a little bit about what we've seen as some findings from that is, again, our assessments are showing that we are seeing improvements in knowledge and skill in the tasks associated with knowledge translation. And you'll have these slides. This is really just for some reading afterwards. In the qualitative analysis that we've done, people really talk about how this has helped them really think about doing their work in a very different way, and how useful they found it in terms of their thinking. When we divide it into some of the key tasks, it's helped them think about finding evidence in a different way. They feel more confident. They feel more confident in their ability to appraise evidence. They have a better understanding and confidence in using different kinds of evidence, and even in producing evidence themselves and in tailoring that into the populations that they speak with. So in closing, knowledge brokering seems to hold promise in a variety of settings. We still have much to learn about the role and about the personality characteristics and about how to train knowledge brokers to be knowledge brokers, as well as on capacity development. And I'll stop there. Thank you. I know we're probably pretty close to moving on, but do you want to take a few questions? Or? All right, well, thank you for listening and enjoy the rest of your conference. It was a pleasure to speak to you.
I would just like to say thank you to Dr. Dobbins. That was great on the knowledge brokering, and I know you had some difficulty getting here, so thank you very much for coming. If we could give her another round of applause. Thank you. I have a few other thank yous I need to do. Before I forget, though, I really would like to say thank you to the Planning Committee. This has been a great conference so far, and I know all the hard work that goes into it. I've watched it, I've witnessed it. So if we could have a round of applause for them, that'd be wonderful. Thank you. And also, I want to thank Market Decisions Research for sponsoring the Continental Breakfast. I want to thank the RPEN organization for sponsoring the coffee and beverage. I, for one, love coffee. Thank you. And to Alliance Enterprises, the creators of Aware, they had a portion of the expenses for this conference as well. So if you could thank them. And now, couple housekeeping things. Can everybody please do their evaluations? I know you've heard that. You're going to hear it a couple more times today. There's supposed to be people at the back of the room for CRC signatures. Can I get you to raise your hand? There's one over here at each door. Yes, there we go. Main people, yes, that's great. So I'm just going to encourage you to move forward to your 2 p.m. sessions and do those evals. Thank you.